I welcome all the participants to this webinar series and to this webinar session on behavioral therapy. There is some technical problem due to which the scientific session will start. It is delayed for 15 minutes. I apologize everyone for this inconvenience. The talk starts at 7:45. So we will reassemble at 7:45. Thank you.
Good evening, ma'am.
Good evening, madam.
Good evening. I'll just check the latest slide because I was actually.
Yeah, I'm a menu 9:40 till 9:45.
7:45. We have announced that 7:45.
Yes, sorry, 7:45. Okay. 7:45.
No, the thing is, I wanted to include some clinical examples so that for residents it is easier. But then I can always talk about the cases as I go along. Okay.
No, madam, you take your time. 5-10 minutes here and there, it doesn't matter.
No, I take this topic regularly for our residents.
Okay.
So, but I, usually prefer if it is away from the institute to use some clinical examples rather than make it only. So I will just locate which one is another 5 minutes. You'll tell me when you're ready to start. Yeah, I am here only.
Yeah.
Hi, Dr. Poulomi.
Good evening.
Bheemsain.
Yes,
Beam.
Poulomi.
Yeah, good evening. Good evening.
Yeah. Good evening, ma'am.
Good evening.
Hold you, Dr. Poulomi.
I'm fine. I'm fine. It's been a long time, I think.
Yeah. Real long.
Yeah, I had some confusion today. I thought it was 8. And
It's okay. It's
was,
okay.
but I have this is something
we have behaviorally managed it, saying that it's a technical issue.
I know, but I'm ready. I can just present slides because I take this class regularly for residents. For many years, I've been doing the learning theory applications for the MD residents at NIMHANS. So I will just move from one section to another. It's okay, and we can discuss as we go along. That's not a problem. I think we can have case-based discussion.
Okay.
I think they've started, I think. No?
Okay. Bheemsain, you can start.
Yes, sir. Vishwas, please start.
Okay. Good evening, everyone. Good evening, everyone. I'm Dr. Vishwas Yadwad here, and I welcome all of the delegates and participants, and to this webinar series on psychotherapy primer. Today, Dr. Poulomi Sudhir, she is going to talk about the behavioral therapies in psychiatry, and I just give it to our. I welcome all them. I welcome Dr. Poulomi. I welcome our Dr. Somshekhar Bijjal sir, IPS-KC Secretary, and I welcome Dr. Abhay Matkar sir, today's chairperson, and I welcome Dr. Bheemsain sir, who is also the coordinator, one of the coordinator, and I welcome all the students and any other mental health professionals who are watching this thing. And I give it to the Dr. Somshekhar sir for any opening remarks.
Okay. Thank you, Vishwas. Good evening to one and all. On behalf of Indian Psychiatric Society, Karnataka chapter, it's my pleasure to continue this series on psychotherapy primer. IPS-KC is doing this activities, webinar activities, academic activities for the benefit of the postgraduate students and the practicing psychiatrists and many mental health professionals in various fields. Last year we did sessions on neurology, neurophysiology, then psychopharmacology, and many more subjects. This year we started the psychotherapy primer. This is the third session which is going on. So I definitely am sure that this will benefit the postgraduates as well as the other practicing mental health professionals. So on behalf of Indian Psychiatric Society, I welcome the today's chair, Dr. Abhay Matkar, who is our past president of the Indian Psychiatric Society, Karnataka chapter. Welcome, sir. And also I welcome Dr. Poulomi madam, who is my teacher, who will be speaking on the behavioral therapy methodologies and all those. So welcome, madam. And I also welcome today's the host, coordinators, Dr. Bheemsain and Dr. Vishwas Yadwad. Also the sponsors of the program, Mr. Arun from the Icon Laboratories, and all the participants who have joined here, and also who have joined on the YouTube channels. Definitely, this will be one of the best program what you will be learning from regarding the behavioral units. So we have experienced that listening to the madam many times. So definitely postgraduate students will get benefited. Over to Dr. Bheemsain.
Thank you, sir. I request our chairpersons for today's session, Dr. Abhay Matkar. Sir is professor and head of Department of Psychiatry, SDM. I request sir to take over and introduce our speaker for today's session and go ahead with the scientific session.
Okay. Thank you, IPS-KC, for giving me this opportunity to chair an important session by one of the most learned speakers of our country as far as this particular topic of CBT is concerned, and more so with the behavioral therapy is concerned. I have listened to Dr. Poulomi on many of occasions. I've attended her programs as such, and I'm extremely happy that I've been chosen to be the chairperson of such an important assignment or a program by IPS-KC. I have the proud privilege of introducing the speaker also as of now. Dr. Poulomi has completed her MPhil in 95 and PhD in 98. She is currently the professor at the Department of Clinical Psychology at NIMHANS, and her main area of interest has been behavioral medicine in NIMHANS. As there is a specialized unit in NIMHANS that provides psychotherapy services, more so on stress and lifestyle clinic at NIMHANS Center for Well-being. Her areas of clinical research and interest include cognitive behavioral therapies, mindfulness-based interventions across psychological and medical conditions, psychological processes in health and health behaviors. She has mentored more than 20 MPhil and 15 doctoral scholars, in addition to contributing to research projects that she is associated with. She has published over 60 research papers in national and international journals in her areas of interest and 7 book chapters. Dr. Poulomi has conducted several workshops for mental health professionals as well as other professionals in CBT and on stress management and workplace well-being. She is a member of professional bodies including IACP, IPS, and the American Psychological Association. She has been a member of IACP Task Force for Guidelines for Psychotherapy Supervision. Over to Dr. Poulomi.
Thank you. I think I can share my slides. Before that, at the outset, I'd like to thank IPS Karnataka chapter for inviting me here. I hope I'll do justice to the introduction and to the topic, because although I've been teaching this very routinely, I understand the applications to a resident is very important. We do have residents who are posted with us, and I think the learning of behavior therapy techniques is the foundation for many other psychotherapeutic approaches, including the third wave therapies, and it forms a fundamental basis. I will take you through some of the theoretical aspects and then keep that minimal and then go on to the actual techniques. What I would probably appreciate is lots of questions and to pause or ask about any clinical cases that you would like to discuss. Otherwise, it becomes like a reading out a chapter or mostly theoretical. So I would appreciate if the audience can raise questions also. Let me just begin by please let me know if it's visible.
Yes, madam. It's
visible. Kindly make your full screen.
Is it full screen now?
Yes, madam.
Yeah, okay. So thank you. And I think without basic theoretical aspects, it becomes difficult. So I'll quickly run through some of the definitions. I promise not to read every line of the slide, which probably will take a long time. What I'd like to emphasize when we're talking about behavior therapy, understand we had a session already on cognitive behavior therapy by Dr. Sudhir some time ago. So what we need to understand is that the two are actually connected in a lot of ways, because we're looking at what does learning actually mean when we do therapy. And behavior therapy is therefore a family of therapies that we see, which consists of many techniques that are broadly related to the field of learning. So when we have clients refer to us for, let's say, for obsessive compulsive disorder, for management of anxiety, for, let's say, social anxiety or panic, we're basically using techniques that are together based on the field of learning. But what we expect therapeutically is the change that we see in the person, and this change is brought about by an interaction with the environment. The change that we see as a result of this learning is also something that will occur rather relatively permanently, and we also see that it is enduring because practice is an important aspect of learning. So what behavior therapy essentially emphasizes is on a change in performance, practice, the knowledge or behavior that changes due to experience, and this is a rather continuous change. Now, most of the definitions of behavior therapy rest on the assumption that behavior is neutral. And when we formulate a case for therapy under behavior therapy or learning principles, we assume that we don't use good behavior or bad behavior, rather adaptive or maladaptive behavior is used, because most behavior is subject to the same laws of learning, whether it is a reassurance seeking that is on continuous reinforcement or an appropriate behavior, learning remains the same based on the same principles. A very quick look at what were the factors that led to behavior therapy, and we're all familiar with the extensive history psychodynamic psychotherapy had, but there are three continents that are largely involved in the growth of behavior therapy, and these are also pioneers in including developing the construct of the idea of behavior therapy, in contributing to learning principle-based interventions, and of course, many interventions that are still applicable. So Joseph Wolpe, we all know, known for his work on systematic desensitization as a therapeutic procedure. Skinner from the US, who contributed and continues to be relevant in the School of Applied Behavioral Analysis and Operant Conditioning. I will talk about some of the techniques as we go along. And Eisen's work, particularly in the application of modern learning theory to treatment of behavioral and emotional disorders. So these are three major contributors, and their work primarily came at a time when psychodynamic work was very, very prominent. The World War had just gotten over. There were a lot of people with PTSD, and treatments had to be very exact and short and time limited also. So this is basically as a result of the growing dissatisfaction that psychodynamic therapy had, particularly in the length of treatment. And most of it was laboratory-based learning. So what are the basic assumptions of behavior therapy? I've mentioned a couple of them. I'd just like to say that when we take a history, when we do a behavioral analysis, which is very essential, we tend to focus on the behavior itself rather than a presumed cause, because what we cannot see or observe or patient cannot report or be reported by significant others may become difficult for us to identify and change. The trait theory to some extent is discarded. However, together, when we talk about personality traits or enduring personality patterns, it doesn't completely discard it, but does look at how these are also manifested in terms of emotions and behaviors. The psychological principles and learning are particularly the focus. So even when we formulate, we try and use try and understand what is the learning history of the individual. And most of these techniques are, although developed in laboratory settings, have had several clinical or anecdotal examples, and the focus is on here and now. So we may not find many studies on systematic desensitization and so on, but we know their efficacy is there. And of course, more recently, newer methods of habit reversal and so on are coming up again in a big way. So the common features, I will want to talk about the specific methods and the learning theories, but the common features across behavior therapies, whether it is exposure response prevention, systematic desensitization, or behavior modification methods, have a few common features. One is that contemporary determinants that are assessed in the functional or the behavioral analysis. Overt behavior is important. However, it does not exclude currently also when a patient says, I'm feeling sad, the manifestations of withdrawn behavior, these are important. It must specify techniques which are spelled out very clearly in the rationale for treatment. Measurement and treatment of behaviors have to be specific and precise, whether it is a rating scale, whether it is visual analog, or whether it is a subjective report of change, but measured on a scale by the patient. And replicability is very important. If I'm doing relaxation and I train somebody or somebody is using it on a patient separately, the instructions and methods cannot differ from one therapist to another. Of course, therapist variables, therapist factors may differ because how I do ERP may be different from another person, but the structure remains the same, and therefore replicability has been proved across procedures. So before we go on to actually looking at understanding these therapeutic procedures, it's helpful to understand the various behavior therapy approaches in a certain way. One is we could understand it from a learning theory paradigm. So there are many interventions based on the classical conditioning paradigm. There are interventions based primarily on the operant or the reinforcement paradigm, and the social learning paradigm, we know from modeling, social learning, and social cognitive interventions are based on what Bandura provided from the social learning perspective. So these are important factors that we need to understand. And I'll take you very quickly through the basis. Otherwise, the techniques by themselves are not, they're not relevant unless we look at the learning theory basis. So this is a formula. I will not trouble you with it, but basically we need to understand that a formula for all the applications are basically how we understand what is the stimulus, what kind of a response are we understanding, what is the consequence, and what is the relationship which is primarily given, when is the reinforcement given, and so on. And I will take you through some of this in a maybe simpler and more practical way. Briefly to look at the pioneers in the three learning theory models. Of course, we are all familiar with classical conditioning, but from the human response or the human psychopathology, the point of view of classical conditioning is that, of course, Pavlov discovered his work through experiments with the dog. We all know that. And just quickly go through this. What is important here, using the classical conditioning, I think the example of post-traumatic stress or phobia is very helpful to understand here. Of course, for the dog, it was a behavior that did not, response that did not require any learning. So salivation was a response that was reflexive, and the SR, the stimulus, which was the food, provided the salivation. Now, if we take a human example of phobia or a trauma experience, the autonomic nervous system and the processes involved in the autonomic nervous system do not require any prior learning, so it is fairly reflexive. And when it gets paired with cues, for example, the place in which the assault occurred or the place in which the humiliating experience occurred, those cues acquire a similar property. So we have the conditioned stimulus, which we largely know in various exposure methods as cues related to the fear experience itself. So to summarize, we have the unconditioned stimulus, which is the actual experience of, let's say, being stuck in a lift or touching something that is very disgusting. And that is something that does not require prior learning. It produces a disgust or a fear response, which again does not require any learning. But when it is paired over various trials with other neutral stimuli, it also acquires the same property, which is now what we know as the conditioned response. So any similar situation can then evoke the same kind of emotional response. Now, what is important in the classical understanding of psychopathology, which is useful for us to apply in our learning theory based work, is that the conditioned response in patients are very different from what Pavlov's dog did or what happened in very primary responses, which are drive-based. So here we know human responses, the conditioned response in phobias or in obsessions and compulsions, when we know there is anticipatory anxiety, emotional aspects are very important. Also, many cues have a predictive value. So a single trial, for example, in a traumatic experience, one need not have multiple experiences of trauma. A single trial is sufficient As long as we know this vehicle or this sound is going to produce or lead to something that is very threatening, it is sufficient to produce a strong response from the individual. The other thing that is very important in learning theory-based applications is the concepts of extinction, which is what we hope will occur when there is a repeated presentation, which we know happens in exposure methods. There is a decline in the strength of this response, and I get habituated and I feel less and less anxious or fearful over a period of time. However, we also know when there is a spontaneous recovery, that is, you've done exposure with the patient goes back home, and there is a return of the fear or the return of the symptoms. In learning theory, we know it as spontaneous recovery because in a very short while, many patients will report they have gotten back their problems and the same patterns have got re-established. So, relapse can be understood as a spontaneous recovery also. So the classical conditioning essentially is very useful in understanding the development of fear and anxiety disorders, largely what we know from the emotional disorders perspective. Of course, there have been many criticisms against the classical conditioning over the years because it's not a simple form of learning that can be applied to complex behavior, and many people may not have had a classical conditioning experience themselves. For example, if I see somebody else being punished or going through a traumatic experience, I need not experience it, but I might develop anxiety responses to similar situations. So the other major contributor from the operant conditioning, we all again know Skinner from his work on the laws of reinforcement and the consequences. The difference is that there is a contingent nature of the response is followed by a consequence, and this finally determines how likely it is that the response will occur. So if it is followed by an aversive experience, then we expect a decrease. Otherwise, we expect a strengthening of this response. A lot of the behavior modification principles are based on the operant conditioning principle. Very quickly, key terms, of course, are the reinforcement, which is a key construct. Even more important is that it is contingent, it is not a simultaneous application. When we withdraw something that is positive, it also becomes punishing. And when we apply something like a rebuke or a memorandum is served or a warning is given to an employee, that becomes a punishment. But when you withdraw privileges, it also becomes negative for the person and reduces the frequency of behavior. Like with classical conditioning, operant also talks about extinction, and this is very critically used in exposure and response prevention, where there is a continuous presentation. When you do prolonged exposure without any escape or avoidance, which is what we expect in ERP, there is a stopping of reinforcement. We expect extinction to occur. Now, contingent punishment is used in many of the childhood conditions. We know that following a certain behavior, let's say in contingency contracting and so on, punishment can also be used. So main concepts include the superstitious reinforcement, which we know as magical thinking in obsessive compulsive disorder, response shaping, which we use very often for training in social skills, and condition reinforcers, which we use in token economies. Token economy is not used very often now, but of course in children's star charts or programs that are based on learned reinforcers can be used. So I'll come back to this when we talk about behavior modification principles. What I'd just like to emphasize is that it's not just the delivery of reinforcement, but also how one delivers these reinforcements. And I'll talk about problems that can occur when the reinforcements are either inconsistent or they are not in appropriate magnitude. For example, the inappropriate behaviors are reinforced with negative attention by a family member, or the reinforcement is given by reassurance seeking of a patient. Sometimes inappropriate, inconsistent patterns of reinforcement actually maintain problematic behaviors. So what is the difference between the two? We have mentioned the kind of learning. One is very reflexive, one is voluntary, one is requiring specific responses by the individual and is modified by reinforcement. Now, in the operant learning, we also know that when somebody wants to avoid, there is active avoidance. That is an example of a operant condition. Now, an important thing to understand is that both by themselves, classic and operant do not explain all of the behaviors, because human behavior is much more complex than we see in laboratory animal models, but they form a good basis to understand some of the habits that are developed. Now, there's a lot of recent work on, let's say, trichotillomania, body-focused repetitive behaviors, many of the OC spectrum behaviors that are maintained purely because they are reinforcing in themselves. So some of the earlier learning theories are coming back into practice. Quickly taking you through some of the models which have led to interventions. One is, of course, counter conditioning, which is linked in systematic desensitization. And I'll talk about ST very specifically also. The third component or the third learning school, which is very important from the point of view of social skills, a lot of behaviors which are used in the social cognitive interventions that we see now was initiated by Albert Bandura. He's the pioneer of vicarious learning. And vicarious learning has bridged the gap between what we know as the SR theories and the cognitive foundations, because Bandura talked about language as being very important. Something that is imitated now or learned now is produced or practiced at a later point in time, because the person is able to remember, retain this information and use it at a later point of time. So language, what we know as cognition or imagery, is an important construct that we introduce as important in learning through observation or by vicarious means. So what is the importance of social learning theory when we talk about behavior therapy in the schools of behavior therapies? We know that modeling is a very important strategy which we use in social skills, which we may use in rehabilitation settings, or even chronic mental health conditions where modeling for social skills is important. Of course, Bandura talked about several prerequisites that are important for learning to occur, particularly in being able to pay attention, to remember, to reproduce feedback, and to be reinforced by the behavior. Why I'm emphasizing this is also because when we know a client has, let's say, neurocognitive deficits or difficulties in learning, both acquisition as well as new learning can be a problem. And the informational transfer that we see in the acquisition of fears or expectancies and beliefs are also important part of the social learning here. Now, self-efficacy, I'm sure when you did cognitive behavior therapy, we know that the beliefs about oneself or in one's ability is important, and that's again a major contribution from the social learning theory perspective. So, Morer's theory I'll talk about when I do exposure and response prevention. I will go on perhaps to summing up what these learning theories are and then go into the particular techniques themselves. I've mentioned a few of them. When we explain a model, a psychopathology model, we usually look at learning theories to explain acquisition and maintenance. This is true even when we use to explain obsessive compulsive disorders, many phobias, or the anxiety disorders where the acquisition and maintenance is possibly explained through these conditioning models. The most comprehensive of them being the social learning model. But whenever you use it in your clinical setting to formulate, it is better to use the combination of more than one, because human behaviors, like I've been mentioning, is not something that can be explained by a single approach or a single learning model. So I will talk about the techniques. I'm not sure if I'll have time to do all of it, but I'll vary the slides and see if I can cover the major intervention strategies so we keep time for discussion. I'd just like to request Vishwas to tell me when I should stop, giving me 5-10 minutes or more for the discussion also.
Okay.
So before we start, you're all used to taking the clinical case histories, right? When we do, when a patient comes to us for the presentation with the problem or treatment, we all take a case history. And the case history, the function of the case history is basically an algorithm that leads us to a clinical diagnosis. And then etiology and models and treatment approaches are logically based on that. However, when we are identifying therapeutic approaches, we use what is known as a functional analysis or a behavioral analysis, which leads to a functional diagnosis, more like a dimensional approach to understand what are the factors that are currently maintaining problematic behaviors. So we use the Cantor and Saslow's model, which has various sections that talk about the description of behavior, right up to what are the family factors that are maintaining it and how are these actually preventing the person from bringing about change, including social expectations. Now, assessment and analysis is a continuous process in therapy. So at various points, we use it to identify if the patient is responding, if there has been a new problem that has developed, there has been substitute compulsions and so on, so that we can bring about change. So using this approach, one can identify targets, plan therapy and monitor progress. We substantiate this with all the rating scales, what you typically use like Y-box, social anxiety measures, or Hamilton's, which will substantiate the information. So that's why we can use a variety of methods, triangulate them, and then use them to formulate for therapy. So for example, product of behaviors is useful, let's say when you're using trichotillomania or treatments with habit reversal, asking them how many hairs did you pull out? Can you produce a sample for a patient who says, I don't know how much I kept pulling today and I don't know how much it was. You can ask them to collect and show you the product so that you can keep that as a measure of change. And self-monitoring is also very essential in most of the conditions, and we'll talk about how that is applicable. So I will start the techniques based on classical conditioning. I won't be able to do a demonstration, but then we are all familiar that at the basis of all classical conditioning methods are those that activate the parasympathetic nervous system. And so the progressive muscle relaxation is perhaps one of the most widely used methods. There are other ways of arousal reduction also. It can also be used to inhibit anxiety responses such as that we use in systematic desensitization. Basically, it counter conditions the anxiety response. Now, there are various techniques that are based on classical conditioning. I've talked about relaxation. Likewise, even graded exposure or graduated exposure, which does not have escape or avoidance because the person is only being exposed to cues, let's say, of getting into a lift and coming out or climbing stairs. For example, if someone has phobia of heights, the exposure is only to those conditioned stimulus without any escape or avoidance and no relaxation method, but it is still based on graduated exposure and systematic desensitization, which is again based on counter conditioning. So essential for the overall arousal reduction is the relaxation response. And for all relaxation strategies, the aims are threefold: to reduce arousal, to increase thresholds for anxiety arousing cues so that smaller and smaller cues don't produce heightened arousal, and the time taken to reach baseline is also important. So if all these are met, then you know that the strategy is working. Otherwise, you may have to review and use a different method or see if the person is suitable or not. So the progressive muscle relaxation is perhaps the most widely used, but we also have a portable method, which is known as the applied relaxation, which is preferred when a muscle tension or arousal symptoms all come together. For example, if there's an interview that I have to attend, and only at that time I'm experiencing anxiety, I can't do the whole JPMR. I have to do something that is very quick and takes a short period of time. So basically, it's something that is based on progressive muscle relaxation, but the time taken, like these steps that I've mentioned, it has about 7 steps, each of which can be practiced over a weekly period of time, and finally the patient applies it in different situations. For example, just before an exam or an interview, I quickly review, see where the tension is, and I apply the relaxation or the release on. So for that, training in the progressive muscle relaxation is important. Blood relaxation has been widely used in generalized anxiety, in social anxiety disorders, but produces the same kind of relaxation in a very short period of time. So another classical conditioning based methods, I've summarized all of it in one slide. It may take many more sessions when you actually do counter conditioning. Just to give you an overview of what are the methods. We don't use systematic desensitization very often now because it's very time consuming. So preferred method is graduated exposure, which is more effective. However, sometimes when there is so much avoidance, or even when a person thinks about something, the anxiety is so high, it is useful to plan systematic desensitization, which is done in 3 steps. Very systematic training in relaxation, construction of a hierarchy, which is either based on time, for example, exam-based anxiety or spatial. Then there is a distance, physical distance. You create a theme-based hierarchy and then expose the patient to the anxiety-provoking cue while the patient is relaxing. So this is where the pairing is occurring rather than one after the other. That's why it is a classical conditioning method. The problem, of course, is when the person has skill deficits. We do not recommend using SD because the actual problem should be handled by the skills training. Somebody who has a fear of driving and hasn't really learned well enough, doing SD will not be necessary. It should be practice with driving that is more important. So what we talked about initially, for example, systematic desensitization, relaxation are all anxiety reduction methods. Now within classical conditioning, we also have anxiety induction methods, and I think the most popular amongst them is exposure and response prevention, which is based on the 2-factor theory that one is acquired through classical, but it's the compulsions and the neutralizing behaviors that actually maintain the problematic behaviors in a continuity. So what happens in the exposure-based therapies? The aim, of course, is repeated presentation of the cue, and the cue, all of the exposure-based methods work on the principles of habituation. So no relaxation to be done while the person is doing the exposure, no compulsions, no escape or no avoidance is to be facilitated at any point, no distraction also. The hierarchy is built based on the cues given by the patient, so very systematic analysis is to be carried out. Imaginal cues may also be used, but the hierarchy is built in such a way that exposure is carried out at least with 50% reduction in anxiety for each cue. So I'll come to some of these steps, which these techniques may be more important. So many of these anxiety-inducing methods, we need to understand that self-directed versus therapist-assisted methods may be both recommended depending on how well the patient understands these approaches also. Now, from the ERP method, the ERP is possibly one of the most popular methods amongst the behavior therapy approaches. Of course, now we have cognitive models that are combined with the pure exposure and response prevention model. So what is the treatment outline for ERP? We focus on the change in the understanding of the obsessions. The person has to be explained the role of neutralizing behaviors and what is maintained through reinforcement. For example, if a patient is using safety behaviors that I don't sit anywhere because wherever I sit, I might be contaminated. The role of neutralizing behaviors need not only be compulsions, it could be avoidance, safety behaviors, reassurance seeking, getting somebody else to check the locks because I may not be able to do a good job. All of these are included in the education to the patient and enabling the habituation through obsessive thoughts rather than trying to get rid of the obsessive thoughts. The focus is on experiential avoidance that is distressing to the patient. And through exposure and response prevention, what is also important is the change in the faulty appraisals that if I don't tap 3 times, something bad will happen. The exposure will also provide for cognitive change in these appraisals. So these are broadly the components when we use educate the patient through the model. I'm talking about a cognitive behavioral model, but basically this includes ERP also, because before you do ERP, if you don't educate, there is a lot of problem with the adherence to the techniques themselves later on. So I will skip this because I think Dr. Sudhir may have talked about the cognitive model of obsessive compulsive behavior and the OC thoughts. So these are the major methods. Now, when we do ERP, I think it's important to also understand that the therapist qualities are very essential. particularly because when we use exposure, clients who are not well aware might use subtle avoidance or substitute compulsion. So you'll see a sudden decrease in anxiety. Patient will say, I'm fine now, we can stop the exposure session, because there are substitute compulsions, or the patient has said it's only a therapeutic session and so on. So it's important to be alert to that, and please give sufficient time for sessions, because about 90 minutes longer, sometimes it takes for a person to reduce even to 50% of what they've been experiencing. Now, when we talk about techniques that are based on operant principles, we are talking about basically the operations of reinforcement, punishment, extinction, shaping, and discrimination. So a variety of behavior modification and social learning theories are based on these behaviors. And you're looking at positive reinforcement, prompts, particularly in children when you're using skills training. Contingency contracting is used in adolescents, a lot of adults also where they're using eating behaviors and so on, and shaping particularly in children as well. Now, the definitions of reward, reinforcements, and so on become important when we understand what is the relationship between. I just summarized it in a table. Now, the confusion often happens between a negative reinforcement. So any reinforcement increases probability of a response and also rewards, and any punishment should by nature decrease the probability of valence of a response. So be very clear when you're using what is happening to that behavior. Is it expectedly reducing, or has it inadvertently increased also? So sometimes when we talk about negative attention parents give to an inappropriate behavior in a public place, it is being accidentally reinforced, and the increase in behavior is what we see. So punishment should always lead to a decrease both in the attraction of a behavior as well as in the probability. So when you select reinforcement practice, we always choose appropriate reinforcers, arrange these contingencies appropriately, that is immediately after the behavior or intermittently, and therefore there should be a reliable response that occurs as a result of these reinforcers. So I've summarized again the types of reinforcers. We can come back to it if there are questions. But basically, reinforcers are not one broad category. There are subcategories within them. And even as individuals on a day-to-day basis, we operate on a lot of reinforcers, particularly like social reinforcers, or even generalized like credit cards, tokens, and so on. And these are particularly used in maintaining long chains of behavior, because when there's no immediate primary reinforcement, people can actually use it in even therapeutic procedures like dialectic behavioral therapy, for example, uses a lot of reinforcement principles as part of structuring therapy. These are the broad ways in which we understand it. However, when we're using it in interventions, we prefer to use social reinforcers, because it is important in shaping, guiding our behaviors in everyday actions. And when social reinforcements are internalized, they also help in validating our own behaviors and preventing when there's loss of reinforcement and depressive responses. Social reinforcements become very important. So to make a reinforcement paradigm effective, we need to keep in mind the timing of the delivery, whether the person has already got the reinforcement, so you're providing it is not going to help. What is the size, amount, and type? So sometimes we find in families there are inconsistent reinforcements provided. A small behavior is given a very large reward, and this becomes a difficult pattern to unlearn, as well as availability and whether there are any biases in the reinforcer. So we presume that all children like chocolate, or elderly people should like certain things, but always better to check what exactly is seen as reinforcer by the individual. So operant principles have a very wide range of application, not just in clinical settings, but also in workplace, educational settings, and very often in non-clinical settings, you find that it has a very vast application. So token economy is another one. I won't go into details only because one, it's a complex system and we don't use it very often unless you are using it in a setting where you want to establish several behaviors altogether. For example, adaptive and maladaptive behaviors together you want to establish is actually set up an economy where people can earn privileges by earning tokens, and the backup reinforcers will be going out for a movie or engaging in some other sport activity. These become the reinforcers which they exchange using the tokens. So the understanding of schedules of reinforcement is basically one sentence that it is a relationship between delivery of a reinforcement and the response that occurs either in terms of time or in terms of number of responses. A simple example is the variable schedule, which we know from gambling, for example. Gambling is a very good example of variable ratio where we don't know when the person is getting the reward. However, the person engages in very, very consistent behaviors. It's also very resistant to extinction. So from the application point of view, behavior therapy, we don't really plan interventions exactly based on variable or fixed ratio schedules. But when you look at school settings, or you have a child with, let's say, extreme inattention difficulty sitting, you could use fixed interval or you could use fixed ratio based on what you establish as a target. So in behavior modification, schedules of reinforcement become very, very important and relevant. So punishment is another problem in the ethical use of punishment, and but punishment is a very integral part of operant models. But the only problem is punishment has difficulties associated with rigidity, because it tells us what not to do, but it often doesn't tell us what we can do to earn positive reinforcement. So when you take clinical history of patients who have had fairly punitive parenting, a lot of parental psychopathology, which has been influential in their socializing, you will find that they have difficulty in flexible ways of behaving, also because punishment has led to a lot of fear in responding flexibly. Also, negative modeling, that is, when I understand that punishment, I can also use force or I can also use violence, which is modeled by the parents and significant others. So some of the behavior modification principles based on punishment are the timeout and response cost. Timeout is not only used in children, but largely used with younger patients. But timeout can also be very relevant when we talk about timeout for behaviors such as isolating a behavior or isolating an inappropriate behavior. Basically, it involves removing positively reinforcing environment or removing a person from a positively reinforcing environment. So in a typical way, timeout rooms in many centers where we look at timeout rooms, they are without any windows, but the window ventilation is there, but nothing that will be unsafe for the person who's in the timeout. There are clear timeout rules. They cannot be used arbitrarily, and there have to be specific times. They cannot be extended timeouts, which can become very threatening or frightening to the child who's in the timeout room. So generally 1 minute per age, but beyond a certain age where the child's cognitive development is quite well established, using timeout may not be relevant. Use more of cognitive interventions or contingency programs where the child can verbalize and be engaged in the treatment. So delivering timeout very effectively is a key to its effectiveness also, because many times it's used as a punishment, purely as a punishment, and that can become problematic. Similarly, they're all familiar with fines. We've all paid a fine at some point or the other, or we've lost an important holiday or an important day because of something else. So response cost is basically withdrawing something that has already been earned, a reward, but it's contingent usually on an undesirable behavior. So one child is, the class is talking and the teacher says no sports period. That's a very crude example of a response cost. Or if you parked in the no parking area, then your bike is seized. These are examples of a fine or a response cost. So, but the response cost should be in a way that is actually punishing. Otherwise, it may not be very effective. So, schedules of reinforcement also include differential schedules. And I think we use this particularly when patients come with, let's say, dissociative behaviors or other behaviors where we want the family to reinforce the appropriate behavior and put another one on extinction. So we might tell the family, ignore the symptom, respond to the patient when he or she is behaving appropriately or interacting with the family. So that is a differential reinforcement schedule in an adult. In children, of course, we look at incompatible behaviors, we look at low probability behaviors and many others which we want to shift, improve one and reduce the frequency of the other. So these are examples of differential reinforcements, again based on schedules of reinforcement. The last one in the approach here is shaping, and shaping is used in introducing new behaviors which are then broken into smaller achievable targets. Self-help dressing I've given as an example. You must know what is the last response that is desirable and then go on till a class of responses, that is the person buttons and buttons more than one button, then the reinforcement is given. It's not that each response is individually reinforced. So there is a class of responses that is identified till a final target is reached. So all of these behavior modification principles require a lot of patience, their assessment and monitoring in terms of the changes that are occurring. Again, contingency contracting I've talked about comes as a major behavior modification approach based on operant principles. So I will talk about aversive therapies later, but I thought I'll quickly talk about habit reversal, because again, this is something you might use very often in your clinical practice. I know a lot of referrals come for trichotillomania. Basically, the model of trichotillomania is such that there is a tick action cycle. We know that this is something that is what is clearly maintaining the problem, and there is a negative reinforcement when the hair pulling or the skin picking occurs, and the tension release is what is the negative reinforcement here. So the target is introducing an alternative or an incompatible behavior. The treatment itself has 4 steps, which is now known as habit reversal training. And the 4 steps, I'll come back to negative practice. The 4 steps involve preparing the patient to use self-monitoring. Awareness is the key focus here. And because we understand habit as something that occurs in a very automatic way. So therefore, awareness is built using self-monitoring. Now, having introduced awareness, many patients, you know that there are 2 kinds of these behaviors. One is the focusing and the other is the automatic one. So we look at recognizing how inconvenient the habit is to the patient, listing out various aversive consequences, for example, of hair pulling or skin picking, and creating a dissonance, particularly poorly motivated patients. Increasingly, we see patients who actually have pleasure or have a very focused way of hair pulling, and therefore, this step increases motivation. This is done using awareness training also, where a very, very detailed record or a journal is kept, and many triggers are identified as passive activities where awareness is least, and the person could actually this behavior could occur out of their awareness. For example, they're reading a book or watching a television, or also under stressful circumstances. So here also we ask them to describe the behavior in detail. So response description, response detection are the 2 things that are done in awareness training. And an early warning procedure where the earliest signs of anxiety are or habit occurring, just the hand moving up the hair is actually detected by the patient and know. And this is an example of how you can ask the patient to actually journal it. If the patient is not able to do it, younger patients, we actually ask the family members to assist without being overly critical or discriminating. We ask them to help the patient actually monitor. Step 2 is deep muscle relaxation. This is not something given by the original structure of habit reversal, but we find it useful because it can be an adaptive coping strategy. And the rationale is introduced and usually helpful when stress is identified in your behavioral analysis as a trigger. And so an alternative coping strategy can be the relaxation response. So deep muscle relaxation is a preferred method, gradually moving on to release only relaxation. The last step here is the competing response, and this forms the focus of habit reversal training. Basically, the overcorrection method is used, and the incompatible response or the competing response is something that is usually in the same muscle group that the person engages in the habit. For example, if it is hand used for hair pulling, then it's the same muscle groups that are involved, which will be tightened. And so the incompatible habit is identified along with the patient. But what is important is that it is maintained for at least 2 minutes or several minutes till the tension is actually identified. This is very important because then a new procedure or a new response is detected and registered by the patient. Now, what can happen is also you can use symbolic rehearsal, you can use cognitive rehearsals to anticipate and solve problems, or you could use covert modeling or a model using instructions for the individual. We initially start with socially inconspicuous situations, involve a lot of practice, and then use it in outside clinic settings also, because the patient may be not very trained or not very confident, and therefore using it outside may be a problem. Now, very often the patient may actually want to pull hair and say, I couldn't, I failed in it and I couldn't do it. So what we ask them to do is again rehearse the steps. Wherever they have not been able to succeed, they go back and continue the steps of the competing response. Basically, like you do in, let's say, for a child with enuresis, where the full cleanliness training is done, where the person is asked to clean, wash up, and so on. So there it is aversive. Here we're looking at establishing a response very strongly. So these are the 3 times where the first priority, like I mentioned, complete 3 steps are done. If they've already pulled hair, as a second priority to interrupt the episode, and third to practice even if they've stopped pulling the hair and the episode has just stopped. In more recent research, they have introduced awareness training using a mindfulness approach where they've looked at some dialectical behavior therapy components along with the habit reversal response. So this is the last step in the preparation and confrontation management. So habit reversal has a lot of scope now, even in OCD. People have tried to use it in compulsions which are occurring largely without being able to identify the obsession. So this is a newer literature that is coming up. The last 2, I think I'm coming to the end also. Vishwas hasn't reminded me about time, so I'm going on.
Ma'am,
yeah, I prefer to take questions because I can go on and on, but I think it will be relevant to have questions. So after this, I think I should wind up with just the skills training. Sexual dysfunctions, again, we know we have the Marston and Johnson program, but like I said, a lot of the strategies under censored focus is actually based on reciprocal inhibition. Basically, when we do censored focus, the primary the focus there is communication, improving sensory experiences rather than a performance and performance related anxiety. So when we know censored focus, the steps in censored focus facilitates communication between the couple, reduces performance anxiety because there is a ban on sexual intercourse, and the 3 stages gradually introduces intimacy and communication amongst them without the threat of failing. So this becomes important. Subsequently, Marston and Johnson talk about specific techniques for male and female sexual dysfunctions, which include either the stop-start technique or the squeeze technique, and the Kegel's exercises for the pelvic floor muscles. But when we plan intervention using a behavior therapy approach, Joseph Annon's work, which is an acronym called RESET, is very useful to plan your intervention. For example, a patient who comes asking about whether masturbatory practices are all right or not, or how frequently can I masturbate? What is all right? So permission and limited information may be sufficient for such a patient, even for reducing guilt if it's not based on any religious understanding. Then specific strategies may be important where patients may need relaxation or may need stop-start technique or may need something very specific. And then intensive therapy, for example, marital therapy or couples work, provided there are issues which are beyond these 3 steps that I described. So this is very useful in a practice where you can be time effective also. The social learning theory I've talked about theoretically, but we all do social skills training, not just for clients who are in chronic mental health conditions, but we know social skills is an integral part in dialectic behavior therapy by itself, in anxiety disorders, in depression, many conditions where skills deficits are the key in maintenance of the mood or the other pathology that we see. So based on learning theory, we could use it in terms of facilitating less frequent behaviors, for example, assertion, acquiring new behaviors, for example, communication skills, approach behaviors, and disinhibition of undesirable behaviors where punishment may occur of a behavior that is undesirable. So social cognitive interventions, again, we see a lot of it now, are used using training material. They are used to build skills, which are again using feedback and reinforcement. So modeling, role plays, role reversals, and role rehearsals are important in the building of social skills training. So this I've talked about as a prerequisite, just a summary of that. And we also look at extinction of fears. For example, if there is a fear in surgery, for example, a child has to go through, guided modeling may be something that is used. So what are the factors that impact the type of model, other people who have undergone it, what is the contact, what are the age and characteristics, and what are the opportunities for the model behavior as well. Should I stop here? And I think I've come to the conclusion anyway. Yeah. So I will stop here with the conclusions, and perhaps it's difficult to do justice to the entire behavior therapy techniques, but I've just listed out a few ones that we use in everyday practice. I'd be happy to answer questions from the audience, and if there are questions in the chat, I can take them as well. Should I stop sharing? And
yeah. Thank you, Dr. Poulomi. It was an excellent journey of behavior therapy per se. I'm sure postgraduates will be able to take a lot of lessons out of this. I think there are a few questions. Dr. Bheemsain, can you moderate the questions, please?
Sure, sir. Madam, the first question is from Ms. Bharti. She asks, is there any role of behavioral therapy in cases of internet addiction?
There is. In fact, much of the strategies are based on behavior therapy principles, particularly when you're looking at the exposure response prevention models are applicable. First of all, the behavioral analysis, I think, is very useful in identifying what are the cues. So we know in addictions, the cue exposure methods are based on classical conditioning, typically identifying what are the antecedents to use of internet. Reward mechanisms are very relevant in internet addiction, but increasingly only behavior therapy is not used in practice because we do know that patients have expectancies from some behaviors. So simultaneously developing alternative skills is important, and identifying the outcome expectancies of the undesirable addictive behaviors. For example, if it's a social media or video game, what exactly is it a skill deficit that is needed? So don't look at it as a single therapy approach in complex behaviors like internet addiction.
Thank you. Sagnik Mukherjee wants to know if you can suggest some textbooks for postgraduates to have an idea about behavioral therapy or cognitive behavioral therapy for beginners.
Cognitive behavioral therapy, Keith Horton is perhaps the cognitive behavioral therapy for psychiatric problems. And we recommend it for everyone to begin with. It's very useful. It also has the explanation of relaxation, applied relaxation, and so on and so forth. I can probably share some articles because BT book we usually recommend women masters, but I think it's too much to read all of it. But if someone has the patience to go through it, I would say that's the classical way to go.
Sagnik continues, he asking, ma'am, sometimes in OPD, if OCD patient refuses admission, what can we recommend that the patient in the brief interactive period to practice at home to alleviate some of his or her symptoms?
I don't know if I can answer that question because first is, of course, to encourage them, may not be admission, but at least on an outpatient basis will the patient come. Many patients may not be necessary to admit them. And if they can come on an outpatient basis, even once in 10 days, whatever minimal is possible, you can start instead of not doing anything.
Okay. Dr. Vishwas wants to know, is there any evidence of using behavioral therapy in eating disorder?
I didn't go into some of the other conditions because they share a common mechanism with OCD and other spectrum disorders because they have some common, it depends on which eating disorders one is talking about. If we're talking about binging or bulimic disorders, then the interventions would be different. But mostly they're cognitive behavioral because they will talk about stimulus control, for example. If you want core behavior therapies, in binging, for example, or overweight and eating excessively, then we could use stimulus control where they manage their eating patterns or they visit the store, but they don't, there are craving also, isn't it, in eating disorders. All of these can be managed using the behavior therapy techniques from the operants too. I would also look at identifying whether there are any other mood-related issues, so behavioral activation. And so essentially, all these don't go by disorder. They go by the presentation and the functional analysis. You could mix and match some of these interventions.
Okay. Anveshan has a question. He says, I have a client who has habit of pulling her hair when she is anxious. Would you please illustrate how we can use habit reversal for this patient, because she mostly becomes aware of this after quite a while?
Ideal patient for habit reversal, if there is, these are the easier patients to work with than those that tell you that, you know, they have that perfect hair that they have to pull out. They spend lots of time looking for it. Whereas this patient, when they're anxious, one would identify probably all the cues related to anxiety. If she can keep a record to begin with, it would be helpful. Awareness training, and then arousal reduction. Maybe many of them have only during exams or maybe during a conflict with a parent, they will have increased hair pulling. So please address the source of the anxiety also, and then use the steps in habit reversal that I've described in terms of the competing listening. When they're doing writing or when they keep the door open and others can see, that's an example of stimulus control again. If I'm not alone, my chances of hair pulling automatically reduce. So some environmental planning can also be used along with the habit reversal.
Thank you, madam. Any more questions? Participants can type in chat box or question answer box. I have a question, madam. Can you suggest some practical manual to be followed for habit reversal, if there are any?
Habit reversal, I think the classical article by Azrin and Nunn is available. And that actually has a diagram also of the habit reversal model. So I think that would be the best way. Many of the behavior therapy texts will have, but it's not something that they describe in a lot of detail for some reason. So I think the article summarizes it.
Abhay sir?
I may have rushed through all the techniques in the anxiety to cover all of them.
Yeah, that's okay. I think it was a wonderful session.
I would have preferred to use a couple of cases, and then explain. That would have been helpful.
Thank you so much. Thank you.
Bheemsain.
Yes, sir.
Before you thank madam and conclude the session, Mr. Arun want to speak 2 words from Icon Lab. Just allow Arun to speak.
Yeah, Mr. Arun, you can speak.
Arun?
I think Arun has some issues with his laptop, sir. He's not able to. The audio is not coming.
You can tell.
No, he's on now.
Yeah.
Is on. Okay.
It's a new brand launch from Icon. Just we wanted to exhibit to all the participants and the consultants, psychiatrists who are participating.
Thank you. We wish this new brand all the success. Can you please stop sharing the screen? Yeah, thank you. I think we have another question. Madam. Yeah, madam, can we take? We have another question. Our chairperson, Dr. Abhay Matkar wants to know, I have a OCD patient and even after applying relaxation techniques, her anxiety is not getting down. I tried using ERP, but she doesn't allow to talk about her obsession. What can I do?
First of all, I wouldn't use relaxation because that would not be a treatment of choice. We've talked about the principle of habituation extinction. Now, why she's not allowing one to talk about the obsession, I think we could go into the content of the obsession. Either it's a sexual obsession or a harm-related obsession, something that is probably something she feels is prohibitory or cannot talk about. And therefore, I would probably first work on that. Sometimes even documenting, writing becomes very threatening to the patient. But I would definitely not use relaxation. A lot of times preparing the patient for any ERP itself takes a long time. So better not to push the patient if they're not ready for it. You could use other things that might allow for exposure. I don't know what the obsession is. If the therapist has some idea about what it is or what are the compulsions that there are, that could give you a clue about what the problem is. So it could be avoidance. It could be reassurance seeking. It could be not visiting temples. I don't know. It looks like a obsession, which is probably something that is embarrassing to the patient, or related to harm-related obsessions where even talking about it could be difficult. So sometimes we could use restructuring methods before using ERP. We don't have to use ERP straight away when clients are not ready because it provides a lot of resistance. So you could use education, you could use normalizing some of these obsessions. I think they're all familiar with Schwartz's work on the 4 R's, the brain lock model, which talks about reattributing, relabeling, and so on. So making it more acceptable, instead of saying everybody gets these thoughts, it might be difficult for the patient to accept. So making it more universal or discussing that these are forbidden thoughts and then talking about what are ways to reduce it, I think would reduce anxiety rather than relaxation. Everything is time consuming. Unfortunately, all the therapeutic approaches are, need a lot of patience from patient, family, and therapist.
Yeah, exactly.
Thank you. Thank you, madam. So before I deliver my vote of thanks, my sincere apologies to Poulomi madam for...
I should apologize because I would have really loved to have clinical examples.
Yeah, no, but I think there was some confusion from our side as well. So my sincere apologies. Nevertheless, it was a wonderful session, madam. And we, on behalf of IPS-KC, I express my heartfelt gratitude and thanks for being here and delivering this lecture, though it was little inconvenient for you.
No problem. I always have these slides, but it's not the way I would have liked to present practical examples and so on. But I hope I can send you something which is specific to my slides, perhaps,
please.
which are more relevant to the postgraduates.
Yeah. That will help the postgraduates.
Even habit reversal and all of them, I'll share it with Dr. Vishwas and
yes, madam. We do have IPS-KC PG group where all postgraduates studying Karnataka are available. We can share these resource materials there and elsewhere. That would be really helpful. So thank you again. Thank you very much, madam, for this wonderful.
Thanks a lot.
My privilege. Thank you very much.
Thank you very much.
I thank Abhay Matkar sir for chairing the session. and handling it very well. I thank Dr. Somshekhar Bijjal, Honorary Secretary IPS-KC, for his constant support for this activity. I thank Dr. Vishwas Yadwad, my co-coordinator. I thank all the delegates for their active participation, and I thank Team ICON for their technical support. Our next session will be on psychosocial interventions in schizophrenia on 8th April by Dr. Matthew Varghese. We will be sharing the flyers and links soon. Hoping to join you there after 1 week, same time, same platform. Thank you, one and all. Good night.
Thank you. Thanks, everybody.
Thank you and good night, sir. Thank you and thank you, madam.
Good night.
Thank you.
Good night. Thank you. Thank you. Bye-bye.